So I thought I'd start off by saying I'm a lucky man, but then I thought actually I arrived here at 5 o'clock this morning and I'm leaving at 5 o'clock this evening, so I'm not sure how lucky I am. But I'm lucky because I have a nice life and I have a nice family and I have a nice time at work as well. And I think those of our age have been very lucky to have lived and seen how brilliantly two diseases have been managed. When I started off in HIV was a complete death sentence, and we've had evolution of HIV care, which has allowed us now to have patients who are going to live to a ripe old age with a good quality of life, and it's now all about getting those people diagnosed to enjoy the drugs. However, in hepatitis C, and I was interested to see the slide in the last talk about evolution, there's not really been an evolution of treatment, it's really been a revolution. Just over a few years, we've come from using horrible drugs with actually very low rates of response to having all of these agents, protease inhibitors, NS5A inhibitors, NS5B inhibitors, to treat hepatitis C, and we can cure. It's not like HIV, it's not like hepatitis B. We're talking about giving relatively short courses of treatment and actually curing hepatitis C. And I think that isn't evolution, that really, truly is a revolution. And really, when we come and talk about implementation of these treatments, what you need to remember that hepatitis C nowadays is a very easy to treat virus. And lots of the things that we're doing are just complicating, perhaps unnecessarily, something which is very easy to give, very easy to take, with very, very high rates of success. And we just need to remember about the drugs. It's useless putting up lots and lots of different studies saying this works, this works, this works. What we need to think of is the basics of treating HIV, hepatitis B, and hepatitis C infection, which is purely this. To have successful treatments, we need to choose agents which have very high potency. Have very high potency against the virus will actually drive that virus down as quickly as possible and keep it down until we have cure of hepatitis C. Equally, however, we need to think about a second characteristic of the treatment, and that is the resistance barrier. We're all aware that individuals will make mistakes with their treatment, that drugs are not perfect, and therefore we have to have this resistance barrier as well. And if we can just think about, with all three of these infections, choosing drugs with the highest potency, with the highest resistance barrier, then we are on the road to success and should be successful with the majority of our patients. But what you have to remember, it's not just about having the right drugs. It's also about having the right patients, of actually making sure patients are aware of how these drugs can have a positive output for them, how to take them. It's not just about giving out the drugs, it's also about educating patients and also educating doctors or healthcare professionals in the best way to actually roll out drugs successfully within programs. And I would come back again and say, all we are doing is often making this far more complicated than it has to be. What we have to think of is a very simple hepatitis C care cascade. First of all, clearly, unless we get individuals diagnosed, we can't treat them. Once we actually get them diagnosed, can we treat all of them straight away, or do we have to assess them? Do we have to monitor them and put them in some kind of order in the importance of how we actually treat them? We also need to think about how we're going to monitor the drugs while we're actually giving them. We need to ensure that patients engage and remain in treatment. It's often very boring being told you've got a disease and you must wait for treatment. So we need to think about how we keep those individuals engaged in their therapy. And we then also, at the end, need to think about how we enhance response. And what I'm talking about with a disease that may be cured, we have to remember that individuals may put themselves at risk again, and how do we prevent them from getting reinfected? So the first thing we need to know is what is the best way of actually diagnosing individuals. And I think we're moving away in many areas of diagnosis away from laboratory tests towards point-of-care testing. And I think point-of-care testing, particularly in a hepatitis C population, is going to become increasingly important. So we can actually diagnose someone within 20 minutes of them actually walking into the clinic, giving them the diagnosis of hepatitis C, and then starting the program of how we get them onto treatment almost immediately. You know, that's really important when we think about the vast numbers of individuals who are chronically infected with hepatitis C, and also the areas of the world where it may not be very easy for the individual to come to clinics, or there is simply no clinic, and individuals have to go out and find these individuals who are infected with hepatitis C. And the important thing about the point of care testing is really down the bottom here of a meta-analysis, that point of care testing for antibodies for hepatitis C is just as good as laboratory testing. So don't think overall you're going to run into problems by rolling out point of care testing. Then the next question is, have I really got it? So we know that individuals who are antibody positive may have gone down two routes. They may have cleared the virus, or that virus may remain in the body. And again, I think the rolling out now, and certainly we've switched away from PCR testing to core antigen testing, again points towards simplification of true diagnosis of hepatitis C infection, and again the potential to roll out point-of-care programs, not just saying, have I been infected with this virus, but have I got the virus? And I think that's really important, that we can talk about how successful these treatments are, but it's really about getting individuals diagnosed. Unfortunately, much of the time, we're waiting for individuals to come to us. And what we really need to do is to think about how do we get into the groups where hepatitis C may be most prevalent. And so you will see lots of programs, certainly in Europe, where this is a disease of men who have sex with men as well as intravenous drug users, of people going into areas where people meet for sex. There are clearly lots and lots of programs where individuals are going out into the drug-using population. But also we need to think about other areas which may be important and allowing us to diagnose more individuals with hepatitis C. And one of those is the emergency room. Individuals with hepatitis C may come from a more socially deprived situation, be unable to access healthcare apart from through emergency rooms. And this is just a small study that came out of Dublin, where they opened up testing for HIV, hepatitis B and hepatitis C within a city emergency department and made it a opt-out. So it's not an opt-in where you ask people, do you want to have these tests? You actually opt out of having the tests rather than opt-in. And if you see the number of diagnoses they made, including new diagnoses and previously known diagnoses who had escaped from routine care, you can see the number of individuals. So they tested around 5,000 patients over 20 weeks, and 287, including 44 new diagnoses, were made for hepatitis C. And so they immediately linked these individuals into care. So it wasn't a case of, oh, you've got hepatitis C. There was immediate linkage into care, and 6 months later you can see the high proportion of individuals who remained linked into care from the casualty situation. Having been diagnosed, though, we next need to ask, do you need treatment? So individuals will say, do I need treatment now? And I think the idea of people waiting for treatment, although perhaps necessary in certain situations, is wrong. Everyone with hepatitis C who is infected with hepatitis C needs treatment. Hepatitis C kills people. We know it's a slow disease, but if you look at individuals who are treated and respond to therapy with cure as against non-responders, clearly if we look at risk of death from liver disease, by treating hepatitis C, there is a reduction in the risk of liver-related mortality. And it's the same for other complications of liver disease. If we think about hepatoma, the effects of positive treatment of a sustained virological response in green on the possibility of developing hepatocellular carcinoma, you can see the reductions by treating individuals successfully. Similarly, if you look at another complication, liver failure requiring liver transplantation, again, by treating individuals with hepatitis C successfully, the risk of liver transplantation, almost in this meta-analysis, almost disappears. So clearly from a liver-related side, it is worthwhile treating individuals with hepatitis C. But it's not just about the liver complications associated with this virus. You should all be aware that just like HIV, hepatitis C is linked to a pro-inflammatory state. So both HIV and hepatitis C are associated with inflammation and complications. So hepatitis C, individuals living with hepatitis C are much more likely to develop cardiovascular disease, bone disease such as osteoporosis, osteopenia, diabetes, lymphoma. So treating individuals with hepatitis C, it's not just about treating the liver, it's also about preventing other complications. So rather than looking just at liver-associated mortality, if you look at all-cause mortality, it's exactly the same. So that all-cause mortality reduces by treating those living with hepatitis C. And if we just look at one other example, this is looking at individuals who were diabetic and looking at renal and cardiovascular outcomes. And again, by treating the hepatitis C, there was a reduction in renal and cardiovascular complications. So, these treatments, it's not just about treating the hepatitis C and eradicating the hepatitis C, it's about reducing both liver and other associated morbidity and mortality. Clearly, by treating individuals with hepatitis C, and the more individuals we treat with hepatitis C, the less the viral load in the population, the lower the chance of transmission. We also need to remember that individuals with hepatitis C are often stigmatized, and treating hepatitis C, removing hepatitis C from perhaps a long list of diagnoses that an individual may suffer from, is also going to reduce stigma. So how do we choose? How do we choose if we implement these programs? Everyone wants treatment. In our clinic, there's no one who says, don't worry, I'll wait. Everyone wants treatment. And people have often said, well, we should treat those individuals at most at risk. Perhaps MSM, there's a call for treating MSM in Europe to reduce the risk of sexual transmission. There's a call for treating HIV-positive individuals, perhaps because of a faster risk of progression of liver disease. But what it normally comes down to is individuals with the most severe liver disease are treated first. So, we've treated all our cirrhotics in the United Kingdom. We're down here treating the chronic hepatitis now at around F2. But it's all dependent on your liver disease. your need for immediate treatment if we are not able to treat everyone all at once. And of course, the advent of machines such as FibroScan, other methods of elastography allowing repeated tests of liver fibrosis have really been very useful in being able to monitor individuals with hepatitis C and their risk of complications from hepatitis C and choosing which patients we should treat first. If you haven't got FibroScan, then it becomes more difficult. It's very difficult to do repeated liver biopsies on individuals, but important to remember there are other simple tests such as the AST platelet ratio index or APRI, which gives us a useful non-invasive marker of hepatic fibrosis. If you've got a large population of individuals with hepatitis C, who's going to treat it? And there's been very much an argument there between infectious disease doctors saying this is an infectious disease, and hepatologists who have said, no, this is a disease of the liver. Now, clearly, both of them can actually treat hepatitis C. These arguments over it should only be a hepatologist or only be an infectious disease doctor is clearly wrong. They do argue amongst themselves continuously, and it's quite clear to me that the hepatologists are very good mechanics, but really this is an infectious disease. Rather like your car, the hepatologist is very good at doing the mechanics of looking for varices, of doing liver biopsies, but we have to remember this is an infectious disease. However, actually, anyone can treat hepatitis C. We said it was a very simple infection. This is a fantastic study from the States looking at the success rates of specialists in hepatitis C, primary care physicians or nurse practitioners who received 3 hours of training. 3 hours of training, and you can see the highest rates of success were actually the nurse practitioners. It is a very simple disease to treat. It really doesn't need a great deal of specialist input to roll out these programs, and it's much more important to actually have someone who cares about the drugs and about the patient and about the disease, rather than someone who is just arguing with others that it should be me. The next question is, what do you treat with? We've got a wide range of choices for the treatment of hepatitis C, and even greater number of drugs coming. So there is a wide choice of treating, and you have to remember that there are differences between the drugs. Not all of the drugs are exactly the same. There are differences, there are good things, there are bad things, there are things that are attractive, things which are unattractive by each of the regimens that we can use. So we do need to look at the data on how efficacious they are, how toxic they are, how easy they are to adhere to. What happens if people fail? And is there an issue of primary drug resistance, drug-drug interactions, and of course, increasingly important is the issue of cost. This is a slide from Jean-Michel Pulaski, which really sort of sums up and makes it unnecessary to show all of the studies. The studies show that the drugs work. People have said, well, those are drug studies, people are cherry-picking patients. What about the real-life situation? Is it really as easy to treat as in the general population as within a drug study where everything is very closely monitored? And the answer is yes. This is real-wide data. This is just from the veterans in the United States, but over 90% success with a variety of different treatments. This is the German Gecko study looking at Harvoni for 8 weeks, SVR rates of nearly 100%. And this is generics. This is individuals who are accessing generics from a generic site in Australia, and again, 100% success. So we can roll out these drugs not only from pharma companies, but also from generic companies with very high rates of success. Toxicities, these drugs are very, very safe. Any drug can have any toxicity, but these drugs are safe. Adherence, as I say, is important. These are very simple drugs to take, the majority being once a day, some as little as 1 tablet once a day, but adherence does matter. If you look at those individuals who do fail in clinical practice, this is a study from one centre in the United States, but the major reason for failure of these drugs, just like in HIV, just like in hepatitis B, is non-adherence. Resistance. So is resistance important? I've just had a debate with the next speaker actually about this in Europe, but we have to be careful when we talk about resistance and resistance-associated mutations. If you look at this kind of data, looking at genotype 1 disease, it looks like there's a lot of resistance. This is looking at primary resistance out there. But if you look at the actual regimens that we give, the association of really what we should be calling polymorphisms rather than the resistance-associated variants, and their possible effect on, these are just the early regimens, not the regimens perhaps which we're giving nowadays, but the actual effect is pretty minimal. We know that these polymorphisms can affect some regimens. You'll all be aware of the effect of Q80K on the cimeprevir when it was given with pegylated interferon and ribavirin, but when we give cimeprevir within a much more powerful regimen with sofosbuvir, the effects of this polymorphism disappears. So if it's 100%, resistance can't matter, can it? What we've said is it isn't 100%. And clearly with some regimens, these polymorphisms do matter. This is looking at the Merck regimen of albazvir and grizoprevir, the effect of resistance-associated variants, both by population sequencing and next-generation sequencing. But you can see the effects of these variants on success. So for some regimens, there is an effect of these resistance-associated variants. In fact, to be fair to the Merck regimen, if you actually prolong treatment from 12 weeks to 16 weeks, if you add ribavirin, the success rate returns to approximately 100%. Similarly, with other regimens, this is looking at Harvonian ribavirin, again, a minimal effect of these variants. But what we can do is not use these drugs. We can look at other drugs, throw these drugs away, and look at more modern regimens. If we look at sofosbuvir and valdapizvir, it's pan-genotypic, almost 100%. If we actually look here at newer regimens, this is looking at the AbbVie regimen, the second generation 2 drugs, again 100% success with 8 weeks treatment, and again practically pan-genotypic. The new MSD regimen, the triple regimens, again 100% successful almost, and no effects of these resistance-associated variants, and the same with the Gilead regimen. Drug-drug interactions, yes, they're going to matter. We know that there are interactions. We need to think about drug-drug interactions, not only with drugs that we prescribe, but also with drugs such as proton pump inhibitors, which may or may not be associated with drug-drug interactions, but also herbal preparations that individuals may be giving. And again, of course, cost matters. Cost is going to matter. I'm just going to talk a little bit about the monitoring because I think that's important, and often the monitoring actually puts people off and actually blocks up clinic. This is a typical diagnostic test and monitoring during direct-acting antiviral therapy. We need to do genotype, but if we use pan-genotypic drugs, we don't need to think about genotype. These drugs are very safe, so really how much monitoring do we actually need? Can we actually reduce that monitoring right down? And there is a study about to start looking again at the AbbVie second generation combination, looking at just really, you test a patient and you see them at the end of treatment and that's it, because there is no toxicity. There is no monitoring that's really necessary. So we should be able to roll out these drugs very successfully, not in a hospital program, but really in primary care. So let me just go through here, because very quickly I want to talk about reinfection, because reinfection does happen. Yeah, and we really need to prevent reinfection. This is a patient of mine in the HIV-positive population. He's been infected 9 times. He's actually gave up sex for 5 years, and he's just taken it back up again, and he's just been infected a 10th time. All right, so people will go out and get reinfected. This is the European data looking at the rates of reinfected in HIV-positive MSM. It's around 25%. At 3 years. And if you're reinfected, your chances of them being treated and reinfected again is even higher. So really important that we think about this, because hepatitis C infection is a behavioural disease. It's not only a viral disease, it's a behavioural disease. Unless we address behaviours and how the world is changing, we can't address the hepatitis C epidemic. We need to realise that the gay scene, and increasingly the heterosexual sex scene, is becoming highly sexualised. You know, within the MSM population, people are not using condoms, they're not so frightened of HIV. There's clearly the possibility of taking PrEP in some populations. People are using lots and lots of drugs. And they're not the kind of drugs that we were brought up, probably not you, but I was brought up on. You know, there are different types of drugs, you know, and it's become normal. It's become normalized to use drugs in the bar and club scene. And the drugs are being used to facilitate sex, and often sober sex can be very challenging. And it's very much a case of fitting in. You know, the drugs allow individuals perhaps to forget about some of the things that would prevent them doing certain activities and being able to fit in with the boys. And it's not that people are going out there to get these infections, it's the effect of these drugs on their self-control. And don't think that it's only a small number of people. This is looking at individuals with hepatitis C in an HIV-positive MSM population, and this is the percentage who admit to using not just drugs, but intravenous drugs. And they don't see themselves as intravenous drug users, they see themselves as individuals who have used drugs by the intravenous route. And I think the warning is that it's also about the heterosexual population. If we look at London, everyone says this is a problem for the MSM population, but if you look at the heterosexual population and similar drug use, cocaine, MDMA, ketamine, it's around a quarter of the heterosexual population who are also utilising these drugs. So the danger is we are going to be punished by putting our heads in the sand. We've done that with the acute epidemic of HCV in HIV-positive MSM, saying it won't happen here. Asia is perhaps the best example where they said this would never happen there, and they're now starting to see an MSM population, HIV-positive MSM with hepatitis C. In London, we're starting to see much more HIV-negative MSM with hepatitis C, purely because we've started looking for it. Previously, we weren't looking for it, so of course we didn't find it. But it's out there, and we now see more individuals with hepatitis C, acute hepatitis C, who are HIV negative rather than HIV positive. So it's really important to think not only about treatment, but how we educate individuals. Educate them about sex, educate them about drug use. Because hepatitis C is curable, and it has an amazing effect by rolling out programs. These are the last 2 slides. But this is the Amsterdam experience, where they actually rolled out hepatitis C to anybody who wanted it in a nice way. And if you look at acute hepatitis C and the rate of acute hepatitis C in an MSM population in 2014, by 2016, by treating the hepatitis C, by reducing hepatitis C in that population, it had gone down by half. So it's not only a benefit of treating an individual, but also the benefit at a population level. And so I think what we have really is the opportunity to treat and cure everyone with hepatitis C. The question is, do we actually really want to do so? Because it's a very easy disease to treat. And as I say, perhaps we make it a little bit too difficult on ourselves. Thank you.